All right, we're going to go ahead and get started. Welcome to this week's session. I am happy to have Anthony Amaya here from Ni2 Health. Anthony is a vice president and expert in all things charge capture. It's a mouthful today. Thanks so much for being here, Anthony. We're glad to have you.
Yeah, thanks for having me.
Yeah, so our session this week, we're going to focus on how to reduce mischarges and increase reimbursement through better charge capture. So let's go ahead and jump right in, Anthony. Why do you think charge capture is such a challenge for healthcare providers and healthcare facilities?
I think the number one problem or thing that makes it the most challenging is a lack of a defined charge capture specific technology to look for missing charges. Random audits using just human bodies can only accomplish so much. Technology really enables us to review 100% of cases, which just isn't feasible with humans alone. I think another challenge is just misinformation or misunderstanding, or like a reluctance to revisit a previous decision, or what I like to call folklore sometimes, meaning people have heard the mysterious they told us at some point in time, which is actually just a fragment of many previous administrations, and nobody knows who they is. I'd say another big challenge is kind of coding accuracy, lack of external coding audits, and of course disbursement of responsibility.
All definitely challenges. Nothing new though for healthcare in terms of, I feel like these similar challenges tend to carry over in a lot of areas, especially the royal they did it that way. We see that a lot. So you talked a little bit about technology. What trends are you seeing in terms of charge capture?
Yeah, I mean, thankfully, I do see trends now moving toward mitigating that human vulnerability through smarter, more streamlined system build and leveraging the existing systems organizations already have. Right. I mean, so for example, many EMRs nowadays can now support charge rules to adjust for charges, for billing rules. So things like, say, like a blood transfusion charge can be automated, even though there's an MUE edit for one per day. In the past, people would not automate this stuff because of the MUE audit, right? Because if you did automate it, then you'll end up billing for too much, or then it'll hit an edit, and then people have to work those edits, and it's unnecessary to work them. And so what happens in this, when you just rely on humans, is of course the charge just ends up getting missed, right? It's also that disbursement of responsibility. They don't know if someone already entered it today or not, so they don't do it because they don't want to hit that edit screen and then be called out for it. But now systems are smart enough; they can allow, even when the subsequent ones get posted or try to get posted, they just won't post them because they're smart enough to know that. Shockingly, still a lot of organizations don't leverage things like these rules, but most of the EMRs are capable now. And I do see organizations looking to build in that kind of smarter, more streamlined workflow now. I mean, humans will always make mistakes, right? And especially if you're expecting like nurses to keep up with billing rules, it's kind of absurd, right? Even if you ask them to and they agree to, it's not something that they're likely going to do well. Having a person work all these edits, that are already known when the rules are completely known, is just wasteful. Another trend I've seen in the last couple of years, really, and this is due to price transparency. Prior to price transparency, many organizations kind of moved to bundling a lot of charges together. So, for example, bundling like supply charges into procedures. But because of price transparency now, I've seen a big trend of kind of unbundling, which is better and more appropriate charging anyway. The lazy way was effective when no one was looking at what your prices are. Now, when your prices are going to look very inflated if you bundled everything into your procedure price compared to your competitors. And with price transparency and your charge masters being posted on the internet for anyone and everyone to see, it's become very important now to kind of undo that. So that's been a big trend as well. which means, charge capture is more complicated too. The rationale for doing that was simplicity.
Right.
But now we have to go back to doing it the right way and doing it accurately and ensuring we capture all the charges.
Do you see any situations where bundling is still appropriate?
No, not that I can think of off the top of my head. Not in the way that I'm describing it. Bundling it for simplicity's sake. There can be some examples of it if you are already very price competitive and you know that even with your bundled prices, and your reimbursement tends to be or is very fixed, then it can still work. It's still not the best probably solution, but it could be acceptable.
That makes sense. That makes sense for sure. Just another question on trends. You talked a little bit about technology and folks are starting to adopt that functionality within EMRs, EHRs. Where do you see resistance to that? Are there certain types of healthcare facilities, geographical locations where folks are still kind of lagging behind the trend or resistant to that change?
Yeah, I think the resistance often is often due to understaffed, lack of bandwidth in IT. All of the organizations that we work with, IT is always overwhelmed and they are always, kind of behind on everything already.
Yep.
So when it comes to, and I think that there's also a reluctance to do something if we already have a process for it and it's working, why do we need to enhance it? And I think the misunderstanding in that is that it's working. When you rely on humans to do things consistently, they're inevitably going to have errors. And if you can automate something,
Right.
why not? So we can help prove that the system isn't working currently, and we can also help justify and rationalize why this should become an IT priority. So I think it's more of a prioritization thing, and just because you have something in place that in theory could work doesn't mean that it can't be improved.
Makes sense. Let's talk about some of the common mischarges that you see pretty frequently.
Yeah, so I kind of touched on one already, and when I talked about in the past, we saw organizations bundle a lot of supplies. There was a reason for that. Supplies are probably the most commonly missed charges. And I think part of the reason for that is if organizations don't have a simple approach to charging for supplies, like just universal scanning, outside of that, if you're expecting the nurses to decide what's chargeable, what's not, or manually type things in while dealing with patients, it's just very unlikely that you're going to have 100% charge capture on supplies under those circumstances. So supplies is a very, very commonly missed charge. Unless an organization has gone to like universal scanning, where you literally just scan everything, whether it's chargeable or not, the system does the rest of the work. That's a solid process. Nurses can do that. And it doesn't interfere with patient care. I'd say the next most common is probably administration charges, administration codes. These again require some coding background. There's hierarchies that have to be followed. There's rules. So if you put that on nurses to do, of course, they're going to, their job isn't to be a coder. So their primary role is care for patients. So they're going to inevitably miss some of that or do it incorrectly. And then coders don't always capture everything. They don't see everything, or wasn't documented appropriately. So for example, in infusions, if you don't document a stop time, they can't charge for the infusion because they don't know when it stopped, and it's a time-based charge. So administration codes are always missed, every place that we've ever looked at. One of the next most common would be bedside procedures. And I think this is one of those things that people get an order, they perform something, and they sometimes don't know that the system isn't dropping a charge for it, or they don't know that it's chargeable. when we look at these things, we see a lot of services being performed, a lot of procedures being performed at the bedside, and no one ever charges for them.
Hmm.
I
Interesting.
mean, it really does. When I look at each organization that I've assessed, it does vary quite a bit, honestly. But those three things are pretty much everyone misses in some fashion.
Interesting. So I think a lot of providers know that they could probably improve their charge capture, but I think especially back to what you said originally about, this is the way we've always done it. There's always some leeriness of rocking the boat or making changes. Where do you recommend that healthcare providers and facilities start? Because it can be a little bit of a daunting task.
Yeah, I mean, the easiest thing if you want to extract value immediately, by the way, even if you don't think your organization has charge capture issues, it would be worth having a third party take a look, because almost every organization does. But so the easiest way to start is leveraging an existing technology or service like what Ni2 Health offers, right, with our charge view solution. That is something where you'll get a team of experts and the software solution with over 1.5 million algorithms. This is the quick way to success. If for some reason you're not going to go down that path, I guess, and if you don't have a technology on your own or internal processes, internal teams, develop the A team, I would start with looking at coding and talk to coders. Coders often notice things that are missing because they're reviewing documentation, looking at charts. They have to code these charts. So they notice a lot of things that get missed. And sometimes they make up for it, but they can't cover everything, right? They still have their specified role and they have their things to do and they have their queues to get through as well. But they will note it, they know quite a few things that are currently happening. You just have to ask them. Also look at what they're responsible for and kind of at that workflow closely. Sometimes people think coding does more than they do. And so there can be a discrepancy. So when we talk to, say, if I talk to nurses in the ED, I'm like, well, who charges for this? And they say, well, coding captures it downstream. And then I talk to coding and they're like, no, that's not part of our duties. And so there can be this discrepancy. So a lot of times when I talk to the clinical departments, they'll say, this is something that HAM and coding catches later. And then when I talk to coding, that's not always the case. And so this is kind of that disbursement of responsibility I was talking about earlier. So really talk to coders, know what their scope is, and then talk to your clinical department. There's likely some gaps in the understanding there. Clinical departments often think about their primary duty as just being their clinical duties, which is totally appropriate. And they assume someone else is taking care of it downstream. But yes, you know what happens when we assume. So of course, I would say look at supply charges as well. I mentioned that already. So an easy way to look at this from a kind of a high level perspective is look at your actual supply revenue, back out your markup, compare that to purchasing. Almost every organization will show a pretty significant gap. And you can easily see when you look at that why there would be a reason to dig into that a little bit further. I also talked about bedside procedures, so do a review of those. This is similar to talking to coders. This time, talk to nurses, understand what they do. Another kind of systematic way to approach this is look at orders. Do a review of your all the orders that get generated, and look at those that don't generate charges. Should they be generating charges? Definitely spend time looking at high cost areas. So look at things like your emergency department. There's always going to be mischarges in emergency, trust me. Look into surgery, look into chemo infusion areas, any areas that have these very high costs associated with them. It's not necessarily that they're more likely to miss charges, it's just that when they miss charges, it's much more costly. I think overall, I would add kind of challenge the group think. So make sure you understand the why behind something. So I mentioned the royal they or the mysterious they.
Right.
And I often call this folklore because when
Yeah.
I often ask people, who is they? Who are you referring to? Can I get a
Right.
name? And usually I hear, well, this was passed on to me from my coworkers, and so I track it down, and it's just a previous manager who no longer works here told them that this mysterious they said that. And so this is what I mean by folklore, where people believe in something just because they said it, and no one even knows who they are. So I'm just making sure you understand the why and just challenge some of it, because it's so pervasive sometimes where people will be
Yeah.
100% lockstep in their responses. Oh, we don't do that anymore. We used to, but then we were told we can't. I'm like, by who? Well, they. Who is they?
Right.
Just make you understand the why and the rationale, and
Right.
not just accept the group think around you.
Yeah. That's really good advice.
I call
Challenge
it
that
folklore
why.
because I hear it almost all the time.
Yeah. Yeah. It's so common too in healthcare for that to just be the response.
I mean, especially
Um,
departments. I mean, they're not focused on
yeah.
that, right? So I see why they don't seek out the why.
Right.
Someone told them who should know in theory.
Right.
Um, that person is also just going off this folklore. And so when we get heavily involved talking to nurses or any clinical department, this comes up a lot. And they're just trusting of someone who told them that. And that's sort of
Right.
appropriate in their role. So we got to be very careful what we tell folks on the clinical side, because it would, I know I said make sure you understand the why, but in certain roles, I can see why you're not going out and researching the why on that. If you're a nurse, if someone in revenue integrity told you this, you should likely believe that. So we got to be very careful what we tell clinicians as well. So they will often come to us and they're like, I've always thought we should charge for this, but I was told years ago that we should not.
Interesting. Huh. I would assume more and more now, especially just with all the staffing challenges that we've had across the board, that people are just trying to like hurry through things, get things done. And so that taking that second to stop and question why you're doing something is probably not happening a lot right now.
Which is another reason to make sure you're streamlining your processes and leveraging technology more. With this
Yep.
turnover and with
Right.
traveling nurses, if you make the workflow as streamlined as possible, where charges are going to drop via the normal workflow and no one has to manually key anything in or
Right.
whatever, much
Right.
less likely to have these vulnerabilities.
Right. For sure. Absolutely. Absolutely. Let's talk about some of the pitfalls. I know we've talked about some of them. What other pitfalls should providers be watching out for?
Yeah, I think the probably one of the most important things that I come across, and I know I probably I might sound a little judgmental in this comment, but I'd say making decisions based on anecdotes. I'm surprised that a lot of the decisions that I uncover that are made based on, I would say, anecdotes being like complaints, right? So people will be can be very passionate about something they're experiencing, and they may come to you, and you as a leader may feel that you need to help them, and you should. But you should also ensure that your decisions are well informed, and you should be leveraging data-driven approaches to make those informed decisions,
Right.
rather than just relying on someone's passion or anxiety. Obviously, that can be very persuasive, but I would say don't make major decisions based on just that. So, for example, we've come across organizations where billing will say, well, adding this charge creates denials and that holds up AR, and this is impacting our cash flow. And all of those things are true, but you need to measure the magnitude of that and
Right.
judge the benefits and the costs, right? So
Right.
they'll make the decision, well, we'll stop charging that or we'll remove that. The worst thing that happens is that billing will then remove the charge as to eliminate some administrative burden that comes with dealing with extra denials. There's much smarter ways to do that too. Systematically, of course, you can, if you understand which payers are doing what, you can do that a little bit more intelligently. but also just making a decision to just remove that charge. So, right, everything upstream happened the way it was supposed to happen. The charge got on there, it was correct, everything's fine. It ends up getting removed, and the claim will go out without the charge. And this is something that people don't often see too. So my other common pitfall is related to this, and that's make sure the charges end up on the claims. If they don't go out the door, you will never be paid for them.
Nope.
And so we see, I kind of just described one example, but we see this all the time, and CFOs, et cetera, will often aggregate data based on the charge data, and they don't even necessarily know if there's no reconciliation to claims data, that 100% of the time, that charge never even went out the door. But you expected that it did.
Right.
Everybody did everything upstream to make that happen. They did it appropriately. But some of this, and I would say related to this is also evaluating decision-making based on dollar thresholds. So sometimes people can make the decision to do that without understanding how large of an impact that is. Another example of anecdotes is an organization, and I've worked with an organization, they didn't want to do any rebills ever, because it creates a lot of administrative burden. They're already short-staffed in the business office, they're already struggling to keep up. And so they just write up everything. And this was kind of a hasty decision. So for example, and there's better ways to address this stuff. So for example, they send out to external labs very expensive like genetic tests, and they don't charge for those things. They charge for those things upon result, but the results take 7 days to come in, but their bill goes out after 4 days. So they're just writing off 100% of these very expensive labs. And there's a simple solution, right? You can just hold, if you still don't want to rebuild, just hold those claims for 8 days. Not everything. Holding all claims would be absurd. Holding just those claims while you wait for the charges is a much better solution. So this is what I mean by using data-driven approaches to make better decisions. Anecdotes are one of the most prevalent things we come across when I challenge a decision. Why did you decide to do that? And they are very, again, lockstep in their rationale and in their reasoning. Well, it was causing all these denials. And so we'll pull the data and we'll show how many denials, we'll show how much it was affecting their credit balances, all the things that they believe are going on. All of the things they say are true. It's just like, did they measure the magnitude of what they believe were causing these things? What was the cost of that? And what's the cost of the decision they've made as a result? Sometimes you can make a decision based on an anecdote that turns out it's fine. It was a good decision. But it doesn't mean you made the decision with the appropriate information. Sometimes you just get lucky.
Very true.
Yep. So I think a lot of times it's the passion that people approach their leaders with, and their frustration and their struggle. And the struggle is real. But sometimes it takes that time to say, we need to have a business analyst really research this, give them a week, let's present the case, and let's make a better decision. Because these decisions can last for years. And we come in to help organizations with this, and we show them the impact of it, and they're like, my God, we've been doing this for the last 5 years, and we've lost $20 million as a result. We had no idea that this was this big of an issue. And it's like, well, you should measure.
Right. I mean, it's really common for somebody to get really worked up over these denials. It's causing so many denials. But if you take a step back and look at the data, maybe it is a significant amount. But also, was it just the last 3 out of 10 denials that person got were all related to X? And so, but when you take a step back and look, it's really a tiny percentage of your overall denials, which you could have just made a decision based on that without looking at the data. And then, like you said, you've just cost yourself, in a lot of cases, millions of dollars because you've made that snap judgment.
Yep. And there's usually, I think the biggest challenge with the anecdotes is not understanding the magnitude, but sometimes it's, therefore you also fail to investigate other solutions. Could you just bill us with a modifier? Boom, no denials,
Right,
because your coding accuracy improved because
right.
you're truly trying to understand the root cause of the denial. So yeah, I mean, the anecdotes thing can really drive too many important decisions. So just be very cautious of that. I guess the last thing I'd say is be cautious of self-auditing. um, Most people will ask a department to do their own review of their own charging practices. Um, and
Yeah.
that's fine. People should look at what they're doing, but if you really want to be sure, you should use a third party or at least someone outside of that department. People are really good at justifying what they already do.
Right. And you're too close to it.
Exactly. I mean, it can't be an audit if it's done by yourself. Like it shouldn't, you shouldn't use the word audit.
Right. Right. Because you look at that every single day.
Yeah, of
You're
course.
too close to it to
You're doing it the way
identify.
you intend to do it. That doesn't mean that
Right.
it couldn't be better though,
Right.
right?
Right.
Uh, yeah.
Right. Let's talk about best practices. What are some best practices that you can share to help improve reimbursement, especially?
Yeah. So definitely, and this is kind of what I started on, but leverage technology wherever possible. So ideally, that's with a dedicated charge capture solution like ChargeView. But and I probably mentioned this as well, most EMRs are capable of doing more than what they're used for. So leverage your EMR even further, even the accessing data out of the EMRs. Um, Most folks may not be familiar with extracting data using SQL reporting, but all of these EMRs allow for very robust SQL reporting if you have someone who knows how to do that. You can make much more informed decisions. You can get answers to a lot of the questions you have. If you have a good data analyst, data scientist, business analyst, who can pull that data, make use of it for you. And of course, I mentioned streamlining your processes as much as possible. Just because you have a solution that works, that's a human solution, you can really eliminate or mitigate the human vulnerabilities through a more streamlined process. So by far, best practice, leverage technology wherever possible. That is really the solution at a high level to ensuring that you get to, no one will ever be 100% perfect in their charge capture, but getting closer to that 100%.
Right.
If you're going to get there, it's going to require technology or better use of the technology you already have.
That's good advice. Let me just ask you a follow-up to that. I think a lot of folks, it's the same thing we've just talked about. This is the way we've always done it. A lot of folks set it and forget it in terms of their EMR, EHR. Do you recommend folks like really get in there, evaluate, make sure that they're using their EMR to its full capacity on a regular basis?
Yeah, I mean, a lot of what can improve charge capture is just reevaluating workflows. For example, if you just sit down with techs and radiology and go over their work, they'll probably tell you things that aren't working or could be done better, or even looking at preference cards in surgery and just sitting down with them and just going over it and looking at the surgeries that are done. These things may have gotten built at one point, but may not be maintained or updated as frequently as they should. And people get by and they use them. Again, in their world, the clinical side of things is most important, right? So if there's a supply missing from the preference card, it's not the end of the world for them. And like as I said, getting access to IT resources can already be a challenge. But if you take the time to review things, especially workflows, especially in those high cost areas, like I said before, it will pay off.
Great advice. Really good advice.
The other thing I would say, again, and this is all related to comments I've already said, but use third parties. if you want to have any objectivity in your findings. The self-auditing, even if it's not within the same department, you'll still have that, a little bit of that justification and rationalization of previous decisions, or the folklore still permeates the organization. So if you really want to ensure that you're capturing your charges, you're going to have to involve some form of third party. And there's lots of ways that can take shape. But if you want objectivity and you want to actually really drive change and improvement, you're going to have to involve a third party, preferably someone with technology. There's, like I said, you can only do so much with human audits. Technology really enables us to do so much more beyond human capability.
All really, really good advice. What's your one call to action for providers? What's the one thing you want folks to go home and do?
Oh man, let's see. Well,
Or more if you've got it. Got more.
yeah, I think one, I mean, just springboarding off what I was just talking about, if you haven't been audited by a third party in the last 6 months, seek one out, right? Obviously, Ni2 is, and you can contact me, anyone at Infinix, Ni2 can help you get connected. Yeah, if you've never had a third party audit, reach out as soon as possible to anybody for help. If you haven't had anything looked at in the last 6 months, or you aren't actively engaged, you are missing charges, and you can stop that. As I said earlier, the quickest and most efficient way is leveraging an existing technology, existing expertise.
Right. Is that your recommendation? Every 6 months, they should have a third party?
Yeah, I actually would say you should always have someone engaged doing this. So, for example, with ChargeView, obviously, it's not just technology. It comes with a whole team of consultants who will help with all the change management, process improvement in your organization. But even if you just have some form of technology, it's kind of like an insurance policy, like a safety net. Technology will can help capture those things that are missed, inevitably, no matter how hard you worked on your processes to improve them. The technology is that additional safety net, and it will capture those things that are going to happen still. So there's almost never a reason to be without it. So you should probably always actively be either engaged with a third party that has technology, or at least having your own technology or subscribing to technology. As I said before, without technology, you'll never have great charge capture success.
It's impossible. All right, we've got a question here. What type of results do you typically see from charge capture audits?
Yeah, it can vary pretty widely. So we often, when we first come in and assess, kind of the middle, I'd say 80% of clients fall into the range of, and we look at 100% of all claims that go out the door. The middle 80% kind of range in the 10 to 20%. This means 10 to 20% of your claims are missing at least some charge. Some are higher than that, especially after, say, like a failed EMR conversion. It can be, there's so many problems and people have no idea exactly what's missing because there's just too much going on. Having the charge capture technology will help aid and identify all those things a lot faster than you can otherwise.
Right.
Yeah, so I forgot where I was going with this now because I thought about the EMR conversion. But the results that we can see are dependent upon that initial audit. So even the best performers that are literally at like the 10%, which is actually fairly good, you're in like the 80th percentile in that case. Even in that case, we see usually at least a 1% lift in net revenue for an organization, which is very substantial when you look at the scale.
Yeah, right.
Mostly hospitals that we work with, but
Right.
1 to 2% is pretty common. And that's a substantial lift. And I know it sounds like a small percentage, but we're talking about millions and millions of dollars. And that 1 to 2% sounds marginal, but it's very substantial. Most of these organizations have operate on fairly low margins already. So that 1 to 2% makes a tremendous difference. And the speed that you can get there is, again, often dictated by technology. Technology alone isn't the solution. As I said, it's still good to have third-party involvement, because we've seen organizations work with technology alone and run into the problem of the rationalization or justification of current activities, right? So if you're auditing yourself and no one's there to challenge you, you'll say, yes, I know that we're not charging for these supplies or these bedside procedures, but they told us we can't. So next. And so the technology may be doing everything right for you, but if you don't have some of that third party involvement, you may still fail to take advantage of that. But through our solution, using ChargeView and our consultancy services, 1 to 2% is very common. Sometimes more, depending on how bad things are. Like I said, a failed EMR conversion, we can help you get back on track much sooner. But yeah, even in a typical environment where things are operating well, you've had other technologies in the past, you've had other audits, still we can usually find at least 1% net revenue lift for the entire organization.
Which is not insignificant.
Nope, not at all.
At all. Yeah, I mean, especially if you're talking about a large health system, that's even a small rural hospital, that's significant. And most hospitals and providers these days need every single dollar, right? So
it was extremely important to these organizations. You'd be surprised at how close some of these organizations operate on cash flow, considering how large and how important they are to the communities they serve.
Right. I think a lot of folks don't think about it. It really is for a lot of hospitals and health systems, especially in the rural health space, that are single-digit days in terms of cash on hand.
And most rural hospitals, for example, operate at a net loss. So they're already digging themselves out of a hole. 1% can change everything.
Right. And what you said is so true. Those hospitals those healthcare facilities are critical to the communities that they serve. And so it's important to make sure that you're doing everything that you can to keep your doors open.
Yeah. And oftentimes with charge capture, it's not adding additional charges or adding services. These are services you're already performing and you should be paid for them. And it's really just about tightening up those processes, leveraging technology, building a better mousetrap.
It's a great way to say it, for sure. All right, I think you're off the hook. I don't think we've got any other questions.
Okay, great.
This was great. Lots of really, really good information. Super glad to have you here. Thanks for sharing all your knowledge with everyone, and hope you'll come back and talk to us soon.
Yeah, anytime. Thank you.
All right, sounds good. Thanks, everybody. Have a great evening, and we look forward to seeing you back here again.